All right, welcome back to another explainer. Today, we are diving straight into the high-yield pathology and genetics of acute, chronic, and special forms of pancreatitis. Whether you're currently grinding through prep for the United States medical licensing exams, or you just want to seriously solidify your mental framework of gastrointestinal pathology, this breakdown is designed specifically for you. We're going to look closely at exactly how the pancreas essentially destroys itself, the honestly terrifying complications that follow, and the underlying genetics driving the rarest forms of this disease. And throughout all of this, we'll be focusing heavily on those blue text clinical correlations that examiners absolutely love to test. So let's get into it.
So let's kick things off with a classic presentation. Meet Joe Mattoon. Joe is 38, has a long history of heavy ethanol use, and he just rolled into the emergency department with a 24-hour history of intense upper abdominal pain. And here is the key feature. That pain shoots straight through to his back. You see that radiation to the back? That's a massive hallmark feature because the pancreas is a retroperitoneal organ. His labs are literally flashing red. Massive leukocytosis, severe metabolic acidosis, and most tellingly, a serum pancreatic lipase level of 926. That is nearly 20 times the normal limit. Now, you might be wondering, why is lipase the focal point here rather than amylase? Well, on your board exams, you must remember that lipase is vastly more specific to the pancreas, and it stays elevated in the serum much longer than amylase. That makes it the definitive gold standard marker for catching this diagnosis. What we're looking at right here is the textbook picture of a pancreas in absolute crisis.
To keep all this complex material straight, here is our game plan for today. First, the acute attack. Second, pathogenesis and pathology. Third, complications. Fourth, chronic pancreatitis. And finally, number 5, special forms. Okay, section 1, the acute pancreatitis attack. Now, even though Joe's case was linked to alcohol, you absolutely need to know that gallstones are actually the #1 cause in the United States, accounting for up to 70% of cases. What happens is the stone travels down the biliary tree and lodges right at the ampulla of Vater, creating a direct physical backup of pancreatic secretions. To keep all these potential triggers straight, the I get smashed mnemonic is basically the gold standard for medical students. Idiopathic, gallstones, ethanol, which comes in second at 25 to 35%, trauma, steroids, mumps, autoimmune, scorpion sting, hypercalcemia and hypertriglyceridemia, ERCP, and drugs. You also absolutely must remember the metabolic and drug-related causes. Hypertriglyceridemia, for instance. This is specifically a risk when triglycerides cross that massive 1,000 milligrams per deciliter threshold, where Tshi lipases break them down into toxic-free fatty acids. Hypercalcemia can also precipitate an attack. And don't forget the specific high-yield drugs like azathioprine, ACE inhibitors, and valproic acid. They are known culprits. But for a quick vignette demographic tip, if you see an older female patient, think gallstones. Younger male, definitely lean toward alcohol.
Moving right along to section 2, pathogenesis and pathology.
So what is actually happening at the cellular level? Well, it's all about this deadly molecular cascade. A rapid rise in intracellular calcium leads to the pivotal event, premature trypsinogen activation. This then unleashes enzymes that literally digest the pancreas from the inside out. Normally, trypsinogen is harmlessly secreted and only activated into trypsin once it reaches the safety of the duodenum. But in acute pancreatitis, calcium overload inside the acinar cells triggers trypsinogen to activate prematurely, right there inside the pancreas. Going back to our patient Joe, his chronic heavy ethanol consumption directly sensitized his acinar cells to this exact intracellular calcium overload. It effectively primed the bomb. This rogue active trypsin acts like a spark in a powder keg. It turns on prophospholipase, which destroys fat cells, and proelastase, which literally shreds the elastic fibers of surrounding blood vessels. The end result? Pure, unstoppable autodigestion. And when you look at the physical damage on this slide, it's pretty wild. On the left, we see interstitial fat necrosis, and on the right, the much deadlier acute necrotizing form featuring intraparenchymal hemorrhage. Look closely at the interstitial form on the left. See those firm, yellow, gray, chalky nodules? That is fat necrosis. When pancreatic lipase attacks the surrounding peripancreatic fat, it splits fatty acids away. These free fatty acids then rapidly bind with circulating calcium to form these chalky white deposits. This is a highly tested process called saponification. On the right, the pathology is much, much worse. When elastase destroys the blood vessels, massive hemorrhage occurs, giving that terrifying red-black color to the pancreatic tissue. And this necrotizing form isn't just a localized problem. It carries a significantly higher mortality rate because of the overwhelming systemic inflammatory response it generates. Okay, let's translate this to the physical exam.
These are your high-yield buzzwords. If you see the Cullen or gray Turner signs on an exam, you need to immediately think retroperitoneal bleeding. The Cullen sign is a bluish discoloration pooling right around the umbilicus, while the gray Turner sign is bruising along the flanks. Both are massive red flags that the necrotizing hemorrhagic process is bleeding freely into the retroperitoneal space. Now, remember that saponification we just talked about? That leads directly to hypocalcemia, because the fat saponification pulls calcium straight out of the blood. The body is literally sequestering calcium to make those chalky soaps in the dead fat, acting as a massive calcium sink that just tanks blood levels. Clinically, you need to watch for neuromuscular irritability. We're talking specifically about the Chuvastic sign, which is facial muscle twitching when you tap the cheek, or the Trousseau sign, which is carpal spasm when inflating a blood pressure cuff. Meanwhile, because the pancreas is being physically obliterated, the insulin-producing beta cells die off, and that results in rapid, stress-induced hyperglycemia.
Next up, Section 3. Complications of acute pancreatitis. An acute attack doesn't just end when the pain stops. Notice how these fluid collections evolve on imaging. Necrosis shows up as unenhanced parenchymal zones that carry a severe risk of infection from colonic bacteria. When tissue dies, it no longer takes up intravenous contrast, so it leaves these large, dark, unenhanced areas visible on the scan. The really scary part about these acute necrotic collections is their anatomical proximity to the colon. Gut flora, specifically bacteria like E. coli, can transmigrate across those compromised tissue planes and infect the necrotic debris. If a patient like Joe isn't managed super aggressively with fluid resuscitation and monitoring, this is exactly how he ends up crashing in the ICU a week later with a soaring fever and profound septic shock.
Now, fast forward a bit. It is vital to note that a pancreatic pseudocyst, which typically develops more than 4 weeks after an acute attack, completely lacks a true epithelial lining. Guys, this is one of the most tested concepts in all of pathology. A true cyst is defined by an epithelial lining. A pseudocyst, however, is merely a pocket of fluid, rich in amylase and other destroyed tissue that the body has hastily walled off using granulation tissue and fibrosis. Because it's just a fragile fibrous wall, it can easily rupture, and that leads to massive pancreatic ascites. But crucially, as it grows, it presses against nearby structures. The splenic vein runs directly posterior to the pancreas. When the expanding pseudocyst compresses this vein, it causes isolated splenic vein thrombosis. The blood is forced to find a new path, backing up directly into the short gastric veins, resulting in isolated gastric varices. That right there is a massive blue text board gem that directly links gastrointestinal pathology straight to vascular anatomy.
All right, shifting gears now. Section 4, Chronic Pancreatitis Breakdown.
We are moving from acute crises to chronic, irreversible damage. Just like hepatic stellate cells or Ito cells drive cirrhosis in the liver, chronic pancreatitis is driven by pancreatic stellate cells. These switch from resting cells into collagen-producing factories. In a healthy pancreas, these stellate cells just quietly hang out at the base of the acinar cells, storing vitamin A. But when they are constantly bombarded by inflammatory cytokines like TGF-beta and PDFGF from repeated attacks, or if they're directly irritated by chronic alcohol exposure, they wake up. They differentiate into myofibroblasts and start pumping out massive amounts of collagen. For a patient like Joe, if he survives his acute attack but continues to drink, this persistent, unstoppable collagen deposition becomes his inescapable future, leading right into chronic disease.
And this slide brilliantly illustrates the endgame of those stellate cells. A shrunken, hard, atrophic pancreas riddled with dense interlobular fibrosis and calcified concretions. Looking at the gross pathology, the gland is basically a rock. The normal, healthy, spongy tissue is entirely gone, completely replaced by white, fibrotic scar tissue. Because the smaller ducts become chronically obstructed by protein plugs and calcium carbonate stones, often called pancreatoliths, the ducts upstream dilate, forming varying-sized cysts. Microscopically, you see massive exocrine atrophy. Interestingly, though, the endocrine islets of Langerhans tend to survive just a bit longer. They float like little functional life rafts in this barren sea of dense sclerotic tissue before they too eventually fail.
So, what does this look like for the patient? Because the exocrine tissue is destroyed, patients develop severe fat malabsorption and steatorrhea, and over half will develop type 3C diabetes, losing not just insulin, but also counter-regulatory hormones like glucagon. You actually need to lose greater than 90% of your exocrine function before steatorrhea, those characteristically pale, fatty, foul-smelling stools, really kicks in. To definitively diagnose this exocrine failure, we look for a low fecal elastase level, specifically under 200 micrograms per gram of stool. This profound malabsorption also means patients completely lose the ability to absorb their fat-soluble vitamins A, D, E, and K, leaving them vulnerable to severe secondary complications like night blindness, osteoporosis, and coagulopathies. And remember, the diabetes these patients get isn't your standard type 1 or type 2, it's type 3C. Because the entire islet is ultimately destroyed by the encroaching fibrosis, they lose their alpha cells and their glucagon production as well. This makes their diabetes incredibly brittle, placing them at extreme risk for sudden, life-threatening hypoglycemic crashes.
Finally, let's wrap up with Section 5, autoimmune and hereditary forms. This table right here is a classic comparative buzzword goldmine for the boards. Type 1 is defined by IgG4 cells in store-form fibrosis, while Type 2 features granulocyte epithelial lesions, though both respond dramatically to steroids. Let's break this down just a little further to secure these points. Type 1 autoimmune pancreatitis is basically the pancreatic manifestation of a much larger IgG4-related systemic disease. On imaging, it classically looks like a diffusely enlarged, sausage-shaped pancreas. Type 2, on the other hand, is strictly localized to the pancreas, and its defining hallmark is neutrophils actively invading and destroying the ductal epithelium. That is exactly what a granulocyte epithelial lesion, or GEL, actually is. Despite these really intense microscopic and systemic differences, the clinical silver lining here is huge. Both types essentially melt away rapidly when you treat the patient with high-dose glucocorticoids.
Moving to the genetics of hereditary pancreatitis, the PRSS1 mutation is the most common culprit. It causes a dangerous gain of function where trypsinogen activates prematurely. This is an autosomal dominant condition, meaning you only need one bad copy of the gene to inherit the disease. Remember earlier how we talked about premature trypsin activation being the exact match that lights the fire of acute pancreatitis? Well, patients with a PRSS1 mutation are born with a highly trigger-happy form of cationic trypsinogen. It activates entirely too easily on its own, which means these patients start suffering from recurring, agonizing attacks of acute pancreatitis right in childhood, long before any environmental factors even come into play.
Conversely, mutations in SPINK1, CFTR, and CTRC cause hereditary pancreatitis through a loss-of-function mechanism. This removes the natural brakes that normally prevent autodigestion. Think of it this way. If PRSS1 is the accelerator being stuck to the floor, these mutations are the brakes completely failing. SPINK1 usually acts as a dedicated cellular bodyguard, specifically tasked with stopping premature trypsin activation in its tracks. When it's mutated and lost, the pancreas is left totally defenseless. CTRC normally degrades runaway trypsin. Without it, trypsin just runs amok unchecked. And of course, there's the highly tested CFTR mutation, famous for its role in cystic fibrosis. This severely alters chloride channels, leading to abnormally thick, viscous secretions that physically plug the pancreatic ducts, causing severe downstream structural damage and autodigestion.
So with all of this reoccurring, profound inflammation starting way back in childhood, we have to ask a tough question. What is the long-term prognosis for these hereditary patients? Decades of relentless cell turnover, chronic inflammation, and massive scar tissue formation take a severe accumulative toll on the DNA of the surviving pancreatic cells. Tragically, they face a 50-fold elevated risk of developing pancreatic carcinoma compared to the general population. A 50-fold increase is absolutely staggering. To put that into perspective, while patients with standard alcohol-induced chronic pancreatitis have about a 5% lifetime risk of developing pancreatic cancer, these hereditary patients are living on a true knife edge. It completely changes the clinical paradigm of their care, shifting the focus from merely managing pain and brittle diabetes to establishing vigilant, lifelong cancer surveillance protocols. Knowing how easily a single inherited protein mutation or a physically blocked duct can turn the pancreas so violently against itself, it really leaves us wondering, are we doing enough to catch this silent killer before the damage becomes irreversible? Something to think about until next time. Keep studying hard, and I'll see you in the next explainer.